Welcome everyone to Go Gentle Australia's Dying to Know Day webinar. Thank you for setting aside time on your Wednesday evening to hear more about voluntary assisted dying and palliative care and how the two can work together. So my name is Steve Offner. As you can see, I'm the Communications Director here at Go Gentle Australia. I'd like to start tonight with an acknowledgement of the traditional owners and custodians of the lands that we're on, and that's wherever we all are attending this webinar tonight. Here in Sydney, it's the Gadigal people of the Eora Nation, and I pay my respects to elders past and present. Next, a few quick housekeeping rules. So this is a webinar, not a Zoom meeting. Everyone is, sorry, that's our light going off. This is a webinar, not a Zoom meeting. Everyone is muted except our host and panel members, and you cannot change that. So that's the way it is for this evening. Everyone but the panelist cameras are turned off. The webinar is being recorded. The recording will be uploaded to our website and sent to all attendees in the next week. And thank you to everyone who sent in questions prior to tonight's webinar. Unfortunately, we won't be able to answer each of them individually, but we have grouped them into themes and we will answer the broad issues that you've highlighted. At the end of the hour, we'll have a 10 to 15 minute Q&A. So if you do have any questions based on what you've heard tonight, pop them in the Q&A box below. You'll see that at the bottom of your screen. Pop them there, not in the chat. You should have an opportunity in the Q&A to upvote the questions that you most want answered. I might get somebody there to pop a question in, just to make sure that that's working. Yeah, thank you, Meg. So once the questions are there, you'll be able to upvote the questions, and at the end we'll try to answer the most popular questions. So without further ado, let's hand over now to our chair for the evening, Go Gentle Australia's CEO, Dr. Linda Swan.
Well, hello there. Hi, I'm Linda Swan. I'm the CEO of Go Gentle, and it's my enormous pleasure to be here to host this evening's webinar. All things, you know, being as they are with technology, with the one thing we didn't count on is Steve and I are in a facility where the lights come off and on. So if we fade between colour and black and white, you know, it's just technology. It's a really fascinating topic that we've got to talk about tonight. It's the interface between palliative care and voluntary assisted dying and how they can work together to offer choice at the end of life. It's obviously a really engaging and interesting topic because we had over 850 people register for this webinar. So it's clearly an issue of interest. And we've had a lot of really engaging and interesting questions put to us by people who have enrolled to participate in this webinar. So we'll get to those later in the evening, but we did have quite a few questions about dementia. And I just wanted to address that up front. I do understand that dementia is a really important question, and there's a lot of discussion and a lot of community engagement and conversations about that topic at the moment. However, it's not the core purpose of tonight's webinar. Tonight, we're going to focus on the interface between palliative care and voluntary assisted dying. But we do recognise that it's an issue of interest and importance to many people. So we are going to look into seeing if we can host a separate webinar dedicated to dementia in the future. But without further ado, let's get on to the topic of tonight, which is palliative care and voluntary assisted dying. And I wanted to introduce our panel. We've got a really broad spectrum of expertise with us tonight. And so it's my great pleasure to welcome our panelists. Firstly, Dr. Sarah Pickstock. So Sarah's joining us from Western Australia. She's a palliative medicine specialist and actively supports people going through the voluntary assisted dying process. So it's great to have her expertise with us, and welcome, Sarah. We've also got Dr. Rohan Vora, who's also a palliative medicine specialist and a GP. He's working in Queensland, also looking after people as they go through the voluntary assisted dying process. And he's a passionate advocate for patient-directed care. I'm also delighted to welcome Sandi Olney, who's a registered nurse, soon to be a registered nurse, a clinical nurse consultant, and soon to be a practice nurse, so a nurse practitioner. So we've really got someone with an enormous amount of nursing expertise, and she leads a team of palliative care experts to deliver palliative care in the community setting. So she'll be giving different insights from that setting for us tonight. So welcome, Sarah, Rohan, and Sandi.
Thank you, Linda.
Just wanted to acknowledge as well, with the broad range and the huge number of people we've got on this call tonight, there's a great difference of knowledge and expertise about voluntary assisted dying and palliative care. So I know there are some people here who know an enormous amount, and there are people here who are just joining for the first time to really explore the topic. So we're going to start at the beginning with some simple questions about what is palliative care and what's voluntary assisted dying. So first of all, what's voluntary assisted dying? Voluntary assisted dying is really a way that someone who is suffering from a terminal illness can legally access a substance to end their life with the support and assistance of registered health practitioners. The term voluntary is very deliberate, and it really emphasises that this choice must be the person's own choice, and that only the person who wants voluntary assisted dying can ask for it. I also wanted to give you an update of where we are with the voluntary assisted dying laws around Australia. We're in a fantastic position now where we have voluntary assisted dying laws in 6 states, and it's up and operating in 5 states. New South Wales goes live at the end of November. So we are in a world now where voluntary assisted dying is available to an enormous number of Australians, the vast majority actually. However, it's not everywhere. There's still work to be done to ensure that there is voluntary assisted dying available as a choice to dying Australians in the Northern Territory and ACT. But there is great progress happening in those 2 states as well. It looks likely that a bill will be put to the ACT Parliament by the end of this year, and the Northern Territory has started work on some community consultation. So I think we can look forward to a future where there is a choice for dying Australians around the country. So I also wanted to just emphasise that we have got laws available in the vast majority of the country. However, there are very strict criteria for who's eligible and who's not, and quite reasonably some strict criteria. There's a lot of similarities between the different states, but the common themes are that you have to be an adult, you have to be at the end stage of a terminal illness, you must have decision-making capacity, and you must be acting voluntarily, and you must be suffering in a way that you deem to be intolerable. So these are common themes for everybody that would like to access voluntary assisted dying. So without further ado, I'm going to turn to our esteemed panel and ask them some of the tricky questions, like what is palliative care? So maybe Sarah, how do you feel about taking that first question? Can you just give a quick layperson's explanation of what is palliative care?
Thank you. I think what I want to start off by saying is palliative care is not just end-of-life care. It is not for people who are necessarily simply going to die in the next few days, have a life-limiting illness. And some of those people might live with that illness for many years. And I guess palliative care, when it is working well for people, really is about addressing people's physical symptoms, and whether that for people is pain or breathlessness. But it's a supportive care as well, and it really needs to support the patient and their family or their significant others to look at how we can make people's lives as good as possible, how we can actually allow people to have a good quality of life. And so it's really broad. It's also for people of all ages. Palliative care is not just for adults. You know, we provide palliative care for children. We provide palliative care for people living with and eventually dying from cancer, but also from neurological conditions such as Parkinson's or motor neuron disease. We can provide palliative care for people with very bad heart disease or kidney disease or respiratory disease. And there will be times when, in fact, we provide palliative care for people dying from dementia. So it's very broad, and it shouldn't be a time-limited thing. It's not that you can't access palliative care unless you're dying in the next 3 months or 6 months, which is perhaps a little different from an American system, which is based on funding. But it's meant to be a broad thing of care and looking at physical, but also at people's well-being, people's psychological and social well-being.
Yeah, I think the fact that it's a very broad scope, I think, is one of the issues why sometimes people get a bit confused about what's palliative care versus what's end-of-life care. And I wonder, Rohan, do you have an easy way that you explain to people what's the difference between palliative care and end-of-life care?
I think Sarah sort of started off with that. I guess it's really very difficult because you talk about approaching the end of your life and then you talk about end-of-life care. Generally, I guess people are settling on end-of-life care is probably the last few days or weeks of life. And palliative care is, as Sarah says, when you get diagnosed with illness, it's most likely to end your life. You don't really know. It might be something else that ends your life. But that you would have symptoms and that could be managed, and it could be years out. So, and I guess the other thing I just like to add is because, Sarah's pointed out very well, it's such a broad spectrum of needs of managing both patients and their carers and families. And it's very much the multidisciplinary team. So it's a team process. And as Sandi will point out later on, it also is across settings. So we really, value having a wide team, and funding wise, that can be a problem, but that's where we aim for.
Yeah, I think the fact that palliative care can occur in so many different settings is one of the wonderful aspects about this part of healthcare. It's not restricted just to a hospital setting. And Sandi, you'd be very familiar with that, working where you are in the community.
Absolutely, yeah. So,
yeah,
place of where people have palliative care or where they want to die is actually another choice that people can make. So, not everyone decides that they want to be dying at home. So there's some people that would like to die in hospital. So it's just their choice. And I think that's what palliative care in the community is, getting people to have their choice at their end of life.
Yeah.
So, yeah.
It's a wonderful, wonderful thing to have that choice.
Yes.
We live in the lucky country. I just wanted to get onto the sort of the meat of this evening's topic, which is really how can voluntary assisted dying and palliative care work together? How do we get that to become a wonderful, seamless process? But first, I think maybe we should ask the question, should they or could they? So, Rohan, do you have a view about whether palliative care and voluntary assisted dying can work hand in hand?
Look, I think they can, and obviously both Sarah and I do both. I guess my feelings are, if you're patient-centered, there's not a huge problem. If you start getting away from that to, well, do I agree with this or not agree with it, then you're sort of into clinician-centeredness or something else, or family-centeredness. So if you maintain the patient-centered approach, then I think they can go together. I guess my worry is that if you separate them, they then start becoming gaps as to how people can actually access palliative care. And as a palliative medicine physician, I get worried that people are choosing VAD because they don't have proper access to palliative care. And I would think, it's really vital that they get full access to palliative care, and then they make a free choice. And if that's the way they choose, that's the way they choose, and we should support them all the way until then, and we can provide palliative care and all the way until they have their VAD substance. and to make sure that they're well supported, their families are well supported, or their carers are well supported, and that they feel supported all the way through.
Yeah, I think that there's broad acknowledgement that we really need to continue to invest in high quality palliative care and make it available to all who need it. I was interested to hear, Sarah, from you. So if we've got great palliative care, why do we need voluntary assisted dying? Where does voluntary assisted dying fit in the palliative care process within your broad spectrum of what palliative care is?
Voluntary assisted dying is about choice. And what most of us value most is choice over how we live our lives. And I think that will be over how when that time comes, we die. And I think it's naive to think that palliative care can relieve all suffering. And suffering can be very physical, like pain or breathlessness, but it can also be that it's distress, it's existential. You know, it can be a spiritual crisis. And my sense in terms of palliative care is, well, first of all, that there is a very big overlap. We know in Western Australia that at the time of people making a first request for voluntary assisted dying, 85% of those people are already in contact with the palliative care services. And maybe part of the shock is that for some palliative care doctors and I think sometimes people are, you know, we're saying almost like, have we not provided enough? But my experience has been, and the team with whom I work, which is both city-based and in a rural area, is that they work well alongside one another. We might have a palliative care team visiting someone every day at home, controlling their symptoms. We've even had people who are desperately sick who've required medication by injection, even in the form of a pump, but who have chosen to make a VAD request. And as that process has gone through, the positive effect that's had on them and that control has actually reduced their distress and their other symptoms. And actually, I think allowed some people to live longer because they know that they have choice. You know, I think that for many people, fearing being out of control is very difficult. And my personal experience, and I've so far in this last 2 years in Western Australia, been directly involved with over 20 patients who've gone down the VAD pathway, every single one of whom has been one of my existing palliative care patients. That choice was absolutely essential, and that it wasn't pain that caused people to decide to go down a VAD pathway. It was about choice. It was being able to access, to die on their terms, surrounded by the people they loved, in the place they wanted to be, on their timescale. And what Rohan says is, this is actually not about me. It's about me and the team I work with, supporting people to do what is right for them.
Yeah, look, certainly choice is the fundamental principle of the voluntary dying legislations. And Sandi, in the community, what's your experience as well? Do you find there are people that are accessing good quality palliative care and still make a choice to access voluntary assisted dying?
Absolutely. Yeah. So all of the people that I get to see and my team get to see are brought into the palliative care program. So I don't see anyone outside of that. So they're already getting what I believe is good palliative care. But there's been one incident that one of my patients rang me and actually said, I can't have you coming anymore, because he wanted to do VAD and he thought that by having our service, he wouldn't be able to access VAD as well. This is very early on in the legislation. And when I assured him that you absolutely can have really good symptom control up until the time that you choose, and it took a bit of convincing, but he was actually my first patient I looked after that took the medication at home, and he taught me a lot. So, and since then, like Sarah, I've looked after about 30 people at home, and a couple in the hospital that have chosen VAD. So, yeah, I think for me, I'm very lucky because the team that I work with we're all on the same page. So without even talking to each other, none of us are conscientious objectors. We just all know that it's a patient choice. And it's not about us, as what Rohan has said. It's not about us at all. It's about our patients. So I think it does work very well.
Ron, yeah.
Just like to add, yes, Sandi brought up the conscientious objectors. Look, in our teams, we will have people who feel very strongly one way or the other. And there's no point going down the track of trying to convince people. You just end up in territory where patients get caught in the middle of it. Conscientious objectors can not practice VAD. It's not an issue, as long as they don't get in the way, if that's what people choose. And there will be a group of patients who will want, as Sarah said, want to control, want to have the medication, and then won't ever take it. But they at least know that they've been through the process. They've got that chance. If things get really bad, they can opt out. And then things don't get that bad, or they choose to not proceed with it.
I think, for those people who've been kicking around in healthcare for some time, we're very familiar with palliative care, but still, I'm sure you're all experts in the space. I'm sure you'd all love more people to be more aware of the services and fantastic value that palliative care can bring to someone's final years and months of life. But I just wanted to ask, and I'll cut to you in a minute, Sarah, but I just wanted to ask, is there ever an instance, when you feel that we should be looking at how we educate people more about voluntary assisted dying? I know that there's still more to do to educate people about palliative care, but it feels like as something quite new, there is a job to be done to make sure people are aware of this choice. Rohan, did you have any, advice on how we can help make people understand that assisted dying is potentially a choice available?
I think it's not just patients. I think it's actually a lot of doctors need educating around the fact that, if someone raises the issue of voluntary assisted dying, they may want to explore that whole path as an end-of-life choice and continue to explore active treatment. And that's not a problem, and it's not a failure. It's a bit like, because palliative care didn't control your symptoms adequately, you still decide to go. It's not a failure. It's just that people really want that wide range of choices and want to explore what all their options are. And I think it's really hard for a lot of doctors as well to accept that, look, it's okay. Your patient suddenly in the middle of a consultation about some new treatment or whatever says, well, what about VAD? You don't have to take it as a failure. You can go, okay, yeah, look, that's fine. You want to explore that? I'll refer you for, to people that can advise you on this. That's okay. Would you like to talk about what I offer, other treatment choices? We can talk about that now. We can talk about that down the track, but you can explore both concurrently.
Sarah,
can I add something to that? Sorry, Linda.
Sure, go Sandi, and then I'll go back to you, Sarah.
Sure. I just think also, I think everyone should be talking about it. We should be talking about palliative care. We should be talking about dying. We should be talking about VAD. So it takes a community to see change. And I have seen change in my community. I know we're in a regional, smaller area, but since the beginning of when VAD was introduced, I've seen a huge amount of change just in my community. People stop me in the supermarket now and talk to me about it. So I think it is up to everyone to be talking about these things.
Yeah, absolutely. Sarah, would you like to talk about palliative care and assisted dying?
Two things. I'd like to just say I agree with Sandi that I think we've seen in WA an enormous change already in 2 years and much more discussion around VAD. And I think as palliative care, we need to remember that, over the 30 years where palliative care has become much more prominent in Australian healthcare, we've seen changing attitudes. And I just think it's going to take doctors a while to get, it took people a while to accept palliative care. And even now there are sometimes people who say, shock horror, if I refer to palliative care, I'm giving up. palliative care is a valid choice for patients. VAD is a valid choice for patients, and we just all need to mature. And I think we're going to do that very quickly. The other comment I wanted to make, if I may, is that some of my palliative care doctor colleagues are actually quite fearful that someone might choose to die because they haven't accessed good palliative care. Certainly here, we've had a number of examples of patients who've put a VAD request in, have ended up speaking to our care navigators in Western Australia, and the care navigators are such skilled and sensitive people that they have realized that some of these patients are not well supported, have had, and what they've done is they've actually reached out to palliative care doctors, helped these patients get appointments, and we can come up with several case examples of people who have still perhaps chosen to have VAD, but often not for many months, because they've actually been able to use the VAD process as an access point to palliative care and had much better symptom control and much better support for the time that they've chosen to have it. So for me, that's been a really good thing of a safety net. And I hope would reassure some of my colleagues that VAD is not that people are choosing to die without having at least had a look at what other supports are available to them.
Yeah. Thanks, Sarah. So what I might do with the panel's permission is actually switch to some of the questions that we've received from the participants. And I'll just read out a question and then I'll just pick someone to answer it. But if someone else would like to answer in addition, please do so. So some of these are trickier questions. I'm giving the panel a bit of due warning. So here's the first one. What if you live in a place that has only one palliative care service and they're opposed to voluntary assisted dying and they will not support your choice? Then it's really an either or scenario, isn't it? So what does a person do? Rohan, how do you feel about answering?
Look, I've been in that situation. This is not in any remote area at all. But I was going to give a case study, for instance, of a patient that I was actually, assessing for VAD, completed the assessments, and she didn't want to die over Easter. She became very symptomatic and needed to be admitted to the hospice. Well, as it turned out, the palliative care practitioner who was on over the weekend for that hospice happened to be a conscientious objector. So I thought, this is a challenge. So I actually, said, well, she doesn't actually want to die over Easter because she wanted to spend time with her grandkids. And I left them with the challenge of, well, why don't you aim to manage her symptoms really well over Easter, and we'll see how she feels afterwards. And I think, as Sarah said, reaching out to the care navigator service or whatever to connect you up with people, or reaching out to the palliative care service and saying, look, there is a symptom management problem. This person actually really does have palliative needs, and they're separate from the VAD needs and they need to be managed. So, and say, look, I will manage the VAD needs. Can you manage the palliative care needs? And you don't have to partake in VAD. You can partake in the best you can offer in the way of palliative care.
We talked a little bit about conscientious objectors and how everybody has a right to be a conscientious objector, but maybe we could delve into that a little bit more. So maybe for people who are newer to the space, they don't even really understand what conscientious objection is. Is that something, Sandi, that you deal with in the community, that you need to explain that to people at all, or is it a familiar term in your experience?
Yeah, well, it is. As I said, I'm very lucky that my little team were all on the same page. But before VAD came into Victoria, I myself was a little bit worried about the legislation, and I wouldn't have called myself a conscientious objector, which means I have a conscious objection to VAD for either religious reasons or ethical reasons. Mine was just a worry that people wouldn't be able to get good palliative care. So when I was working with my patients, they were able to teach me that actually it wasn't about me, it was about them. So I have got, so outside of my team, I work for a larger organisation, and within that organisation, there are a lot of people that say that they conscientiously object to VAD. Now, some of these people are in palliative care space as well. So, and that's their right to do that, absolutely. What really upsets me is when that interferes with the patient choice. So I have actually had to have some pretty awkward conversations with people that are a lot higher up than me to advocate for patients that do want to see their choice being made. So I've even forgotten what the question was now, Linda.
Oh, no, that was wonderful.
I feel like I'm rambling.
Okay.
Yeah.
Why some people do make
Yeah.
a conscientious objection.
Okay.
And Sarah, in the hospital setting, is this problem largely solved, or is it still an issue as well?
I think it is still an issue. And I think there is actually a small group of people who have a deeply held religious and ethical position that would never allow them to hasten a patient's death. And I respect that.
Yeah.
I think a lot of people are actually still just scared about voluntary assisted dying because they don't know what their position, they don't understand what their role is. And I think that many doctors are just not confident talking about death and dying in general, and therefore VAD has them running for the hills because they don't want to confront it. So my sense as well is that there's a very small group of people who are adamantly opposed, and there's a big group of people who are just kind of almost being a bit avoidant. They're not sure what it will involve, they're fearful, and they're worried it'll be more work or something else. It certainly is difficult in Western Australia because 2 of our large hospices are run by church organisations, and both of those hospices have taken a position around not supporting VAD. And yet I'm proud to say I also work in a regional area where the hospice is run by the GPs for the community, and they have provided excellent palliative care and VAD services because that's what the community asked of them. So in answer to if a patient was in a situation where they're in a place where there was only one palliative care service who made it clear that they would not support it, I would also take them back to their own GP. And I would ask them to, perhaps we could try and access through their GP to see if we couldn't use telehealth into another palliative care team. I would be very disappointed, even if someone lived in a small area, that we couldn't find someone who couldn't, look after them in some shape or form. And my experience as the team also is that what the nurses I work with often say to me is once they've experienced a VAD death, it has actually for many of them changed their whole position on the subject. So it's gone from one of, that's not what we do, it's not part of the definition of palliative care, to we've had many nurses who've been invited by patients and families to actually attend, when they die. And the nurses said, well, what should we do? And we've said, if you want to go, we as an organisation will support you. You can take that time. And without fail, the nurses have said that what they have witnessed has been very peaceful, calm, dignified deaths. And if anything, as each death goes by, the nurses and the other people I work with are more pro-VAD with each death rather than more against it. And I think for some people, and me included, it has actually been quite challenging because I've looked at my existing palliative care practice and what a palliative care death looks like, and says that it's not as good for some people as they would want it to be. And I think some palliative care practitioners have perhaps been threatened by voluntary assisted dying because it actually puts the thing up and says palliative care is fantastic, but it's not fantastic for everyone. There are still gaps in what we can provide, and we need to know that for some people VAD fills that gap. And that's not about being able to access palliative care. It's about there are limits to the drugs and the techniques and the staff we have. And I think we need to know that we live in an imperfect world and we provide an imperfect service. And that's why we cannot gatekeep people's choice to access VAD.
Yes, I've certainly heard a story from my colleagues and other people that I've, other doctors that have been contemplating working in voluntary assisted dying and being a bit cautious about it and nervous about it, and actually then describing afterwards that it's been an incredibly rewarding and fulfilling part of healthcare to be involved in. So I'm hearing themes like that every day as well. So I don't think it's an isolated example. It's surprisingly rewarding, I guess, is a question that is a response I often get. Rohan, what's your experience of talking to people, health professionals working in the space? Is there still quite a lot of angst about being involved?
There is angst. I mean, the interesting thing for me is a bit like, Sarah, I actually find goals of care discussions now a hell of a lot easier, because it's, well, what are we actually trying to achieve? Are we trying to focus on prolonging your life, in which case the whole gamut of things, as well as, well, maybe we'll make you comfortable as well, but you need to be heavily involved with the active treatment side of things, and we'll just be there as supportive care. Are we starting to focus more on your care needs and not so much on life-prolonging things, or maybe just simple life-prolonging things, not more than that? Or are we at a stage where we're now just letting nature take its course and just making sure you're comfortable? Or are we at a stage, where you're choosing VAD and you've got to a point where quality of life is really bad, and you'd like to just, get around to ending it? What are the discussions you'd like to have with who, what, where do you want it? What are the discussions? So I find it's actually clarified things for me a lot better. And when people sort of start saying, oh, look, you're just practicing VAD, I go, well, no, I'm not. Because if I was practicing VAD, this is what I would be doing. And however, this is not what I'm doing. And the reasons are because I've had these discussions with the patients. And this is where they want me to aim my treatments. So I find it easier to actually talk with other clinicians around that. And even in an environment where there's a lot of conscientious objection, it's actually easier to clarify goals of care.
One other level of support or area of support that I consistently hear is very highly valued are the care navigators or the care coordinators services. And, I've heard them frequently described as angels. People seem able to really discuss openly and honestly what their needs are and what they're looking for. And it seems to be such a welcome service for people. Maybe sometimes it's hard to talk to your doctor that's been looking after you for years about end of life, and it's easier to talk to a care navigator who's really very familiar with the assisted dying process. Sandi, have you had much to do with the care navigator services? Is that something that you are in touch with?
Absolutely, lots. But also the navigators could also help out with those people that don't have access to palliative care, whether they don't have a service in their area, so they can actually know how to get to doctors that will help them. So they're really, really important, because there are gaps in our service around Australia. There definitely is. So the navigators know which doctors can help out, and they do actually refer. I've had referrals from the navigators to our service as well. I've also been asked to do telehealth as a palliative care nurse to people outside our area that haven't been able to access palliative care. So I've been able to do that as well. So they're amazing, amazing people.
So I guess this is a question to you all, but one of the things that can happen is that, the best laid plans, you've had fantastic palliative care and you've come to the end of that journey, and you're at the end of life, and you make a choice and a decision that you'd like to access voluntary assisted dying, and you go through the approval process. But then something happens, you wanted to die at home, you had it all planned, but something happens and your healthcare deteriorates and you need to go to hospital. Does that turn the whole process upside down? And Sandi, what's your experience? What do you do in those circumstances?
I actually had a lady just very recently that she had her medication with her at home, and she ended up having a bowel obstruction. So that means that she wasn't able to take the medication that she wanted to. So she ended up in hospital, which was the last thing she wanted. But she was actively dying. So she was very unwell. And so what she wanted, though, she actually wanted to still do VAD. That was her wish. So we ended up going through a process where we sent the medication back, and she was able to change that to what we call physician assisted, which means a doctor does that for her. And I believe that it was the day that she would have died naturally, she had that medication. And it was pretty amazing. So she was actually so determined and so ready. And yeah, it worked really well.
Yeah, that's a great story. It's. What about you, Rohan? Is it always like that? Is it sometimes a fairly straightforward process getting from community into hospital, or?
Not necessarily, because it depends on beds and availability. If you say that you want to go in to have VAD, it's unlikely that you're going to just get straight in, because there's going to be a lot of, I don't know where Sarah's up to, but we've been thinking and negotiating that we have some control of beds, but we're not an admitting service as a VAD service. But under Sandy's sort of example, coming in with a bowel obstruction or some other symptom management, yes, you come in. And then if you decide you want to go ahead with VAD, and if the method needs to change, well, it can change. And that's where the care navigator services are really important, is to navigate you through all of those. If your own VAD service is not able to do that, the care navigator service will step in and try and make those transitions as smooth as possible. And I mean, in Queensland, yes, we can transfer, administrators and practitioners, the type of administration. It's just another form to fill out, and you can go through that and change it as needed and explain why. It's not a problem.
So just one last question, and then I think we'll turn to see what questions we've had from the online audience. One of the questions we had before from the audience was about the issue of, is it okay for a palliative care team or a hospital to essentially refuse to help you with your wishes for voluntary assisted dying? Is that something that any of you have experienced? Is it something that is largely, now no longer in place, or doesn't happen? Go, Sarah.
Okay. I am sad to say that I do still think that is happening for some patients. I think it's going to happen less. And as time goes by, hospitals who have never actually had a patient die by VAD in their hospital, it's almost like once you do it once, you realise that the world does not end. In the regional centre in which I work, we have a fairly large hospital, and up until recently, everyone who had wanted to access VAD had gone across to the hospice. We had a stage where we just didn't have any beds in hospice, and we've had 2 patients die in that regional hospital, and the hospital did it extraordinarily well. And suddenly it's saying, well, we can do this. Excellent. So, and I think earlier we talked about conscientious objectors. I think some people are just objectors. And I think sometimes once you've done something once, you realise you can do it. But we certainly in Western Australia still have a couple of facilities who don't feel that they want to, would not be prepared to administer VAD or have a patient take a VAD substance. And so what they say is that they would ask another facility and transfer that patient. When I'm working in the community, what we would then try and do, if we knew a patient really wanted to access VAD, we would try and steer them and get them admitted somewhere else so that their whole journey was smoother. And certainly the palliative care unit in which I work, we would not really want to be a place, to be honest, well, at the moment, where people came purely to be a VAD location. you know, because beds are precious. But if someone, as Rohan said, if someone came in with symptoms and as part of their admission chose VAD, then we would absolutely support them through that. But I think this also has to be taken up by the whole healthcare system. It can't actually all just sit on the hospices. It needs to be every hospital everywhere needs to be prepared to actually look after patients as the law says we should.
Yes. Yeah.
So what would you advise someone if they are in that unfortunate circumstance where they really feel that their wishes aren't being heard? Rohan, as a big advocate of that patient-directed care, what would you say to a patient? Where should they go? What should they do?
I think that the default will be the navigator service within your state, or in Queensland, it's called the Queensland Voluntary Assisted Dying Support Service. But, you know, once again, it depends on the community, whether there's VAD units or whatever around that are supportive. You can get GPs that are very antagonistic to it and won't have anything to do with it, and won't even refer on, even though there is in Queensland a legal requirement that you either tell them straight away if you're actually a defined conscientious objector, or if you're having a think about it, you've got to let them know within 48 hours about whether you want to refer them to somebody else or whether you want to take it on yourself and have discussions with them. So I think that gradually over time, people will go, okay, that's all right. Someone doesn't like, they don't want to talk about this topic, but I've got the default. I can phone, you know, this number in my state or in my health district and get my, you know, and it may just be questions. It may not be even that you want to necessarily explore. You might just want to explore the whole idea of it and what it means.
Yeah. Sandi, what about in the community? Is it different in the community if someone's struggling to have their choice supported? Where should they go?
Definitely the VAD navigators would be the first person. Unfortunately, in Victoria, we have a little bit of a law that says that we can't actually talk to people about VAD unless they ask us. And so there are a great deal of patients that I don't see, that our team doesn't see, and that will do VAD at home just by using the nurse navigators. I mean, they don't have to have a palliative care service. So I think the navigators and also GPs in our area are the people that we would rely on to make sure that VAD is recognised.
Sarah.
So I was going to say, just the participants, we will share later all the Care Navigator contact numbers. And certainly I was going to say, in WA, a member of the public is perfectly entitled to ring and talk to the Care Navigator service for advice and information, because they're not counselling people around VAD, they're purely telling people what their rights are under the law, and therefore they can give people information sheets and contact numbers. So yeah, certainly in Western Australia, I'd say contact our Care Navigators, and they will help you in a really sympathetic and supportive way to get care. Because I agree with Rohan, not all doctors are on board, or not on board yet. But in an era where, if COVID has taught us anything, it should be that telehealth can provide a lot of this. And at very least, we should be able to find a palliative care or doctor or another GP who can at least talk to you by telehealth about your palliative care options, of which VAD is part. So yes, we must be able to reach out. And my experience is when people want to access VAD, you know, we've had people die in their own homes, we've had people die in hospice, we've had people die in a regional hospital. All those things are possible. They really are.
Thank you for answering those questions. And now I might just check with Steve. Have we had some questions from the online audience, Steve?
Hello, everyone. Yes, we've got quite a few questions that have come in, and I do encourage people to upvote the questions they'd most like answered, then that will make it a lot easier. So if we just go to the top, I guess it comes back to the question we touched on before about when can you access palliative care? it seems that a lot of people have experiences where they're only really getting palliative care services when they're nearing death, where they're right at death. So the question is, how do I access palliative care when the doctor has the view that I only need end-of-life care? And it comes back to the advocacy, I guess. Do the palliative care physicians have any views on that?
Yep. Look, it's Rohan, it's difficult. You know, if you look at Palliative Care Australia's website, there's been a lot of work on that. You know, that's the ideal. Is that just as Sarah said, palliative care should be offered when you have been diagnosed with an advanced illness that's likely to end in your death, you know, maybe years down the track. But then funding issues start playing up and people start going, well, we can't take on that many. We'll start limiting what we take on. So maybe we'll just take on the last 3 months of life.
Yeah.
Now, a lot of services have gradually over time worked away from that to the last 6 to 12 months of life at least. And some services are able to, at least on a supportive care basis, on and off take on patients. You know, Sarah talked about that may be quite a long way out from that. So I guess it goes back to, if you feel that you've got symptoms that are not being adequately managed, then you need to, you know, really try and get connected with your specialist palliative care service. And if there are barriers to being connected because they've sort of said they're 3 months or something like that, I think you just keep getting your GP to refer in. And, you know, unfortunately, the noisy wheel ultimately gets looked at.
Sarah, any other advice?
I think we also need to remember that there are specialist palliative care services, but there are also awesome GPs out there providing good palliative care. So different people need different things. Some people need the whole package of palliative care. Other people want a lot more medication advice. I think ideally people should also be able to dip in and out of palliative care, perhaps see a palliative care specialist or a specialist team, get some advice, and then go back to their own, you know, their own respiratory physician who's managing their chronic airways disease, or go back to their renal physician because they're still having dialysis. I certainly think that when you talk about them VAD, and the legislation in Western Australia is you have to be thought to have a prognosis of 6 months or 12 months if it's a neurological disease before you can access VAD. That largely does put you into the time frame when you should be able to access palliative care specialist services. So, you know, if your prognosis is 5 years, you know, as best we can guess, yeah, you might struggle to access specialist palliative care services because the pot of money just doesn't go that far. But they would not be people who would be able to access VAD either, just because of the proposed duration of their life.
So there's another question here. This one's from Dr. Greg Mewett, who's a palliative care physician and VAD practitioner from Victoria. Hello, Greg. I think Greg's question might be very relevant to palliative care or not. And it's a question about the practitioner administration of VAD versus self-administration. And Greg makes the point that in Victoria, the vast majority is self-administration, whereas in WA, it's pretty much the opposite. Does this have an impact on the palliative care services, the administration method that you choose?
It is interesting where there's a difference between states. And I think West Australia had not anticipated how many patients would choose physician administered. One of the biggest challenges is that, you know, West Australia is a very big state and many people live outside Perth, and it has actually been quite hard to be able to get doctors flying and driving to rural areas to provide that service, but it has happened. I don't think it, you know, for us as a community palliative care service, I don't think it has impacted on us. We as a service have taken on the view that it's a patient choice. And quite often we have had palliative care nurses who have been invited, as I say, by the patient and family to be in the home when the physician has actually administered the medication. And then they've often actually helped be there to then help the family actually do things like lay out the body, prepare the person's body to be picked up by the funeral director. So, but I know that other palliative care services would say that that is not something they were happy for their staff to do. So I think it still varies a lot. But for us, for my palliative care service, I don't think the method of administration has made any difference to us as palliative care.
I'm wondering if
Sandy
Sandi has yeah.
Good on you, Greg, for setting that through. I know, Greg. Well, in my experience, you're quite right. There's very minimal physician assisted, and I think that's probably because there's not the doctors that are willing to do that. So a lot of the doctors that we work with, GPs or physicians like yourself, are happy to prescribe the administered route, but aren't happy to do it as a physician assisted. And that's absolutely their choice as well. So we've probably got one in our area. And that's probably why we don't see as many people doing the physician assisted. I don't think it's, I agree with Sarah, I don't think it really matters which way they do it as long as they've got access.
Thank you. And another question here from an anonymous attendee who says, retired nurse, supportive of VAD, it's their wish to access this form of death when the time comes. But what happens, for instance, if you're applying for VAD and you're maybe partway through or all the way through and you have a stroke, for instance, and you're no longer capable of making a decision? What happens then? And there are a few questions about this, about requesting VAD in an advanced care directive, for example. So maybe we could answer that question.
That's Sarah. Yeah.
So you cannot, I mean, in an advanced care directive, you can talk about what your beliefs are and what you would like to happen, but you cannot pre-plan voluntary assisted dying. But then the next thing is that the law says that you have capacity until someone proves otherwise. And there will be many people who have a stroke and you could lose the power of speech, but that does not mean that you've necessarily lost capacity to make a choice. Equally, I mean, I have patients with motor neuron disease who have no ability to speak. And we've had a patient who had made a voluntary assisted dying request. And as he was losing his power of communication, we were practicing every day, literally doing 1 blink for yes and 2 blinks for no, because we knew that the time would come if he wanted to make that decision. He had to be quite clear that he knew what he was agreeing to. So you don't have to be able to speak to have capacity. So I think, but if someone has lost capacity, then VAD cannot proceed because that is how the law is worded. And at this stage, that's where it stops. But I think the other question I hear from people is almost, if someone is getting sicker and requires sedation, what if they then lose capacity? Well, we shouldn't be sedating people unless that's what they want. I do think sometimes people get sick very quickly and actually die before the VAD process goes through. But equally, if I felt a patient needed some sedation and the patient said, don't sedate me because I don't wish to lose capacity, well, then I shouldn't be sedating them. Patients have choice and I can't be giving them drugs that they don't accept. I think that's how I see things.
Okay, thank you. Just working our way down the list, and I think it's a question that a lot of people have. Does a mental health condition restrict people from being able to access VAD?
No, I can deal with that. No, it doesn't. If there's any question, obviously, from family or whatever, with the dispute, then it's important to try and get a psychiatrist or somebody involved. But just because you've got, depression or other mental illness, you can still retain clarity around, what it is that you want and around suffering. And it would be, crazy to sort of suddenly just wipe people out because they've got a diagnosis of a mental illness. But yes, one does need to assess that. And as Sarah said, it's a question of assessing capacity. It's a question of understanding what it is that they're actually asking for, what the import is of it. And no, they should be entitled to access that.
And I guess there was a similar question too about dementia. Having a diagnosis of dementia doesn't necessarily rule you out from accessing VAD, does it?
It goes back to capacity. And, capacity, you can have if you want to do mini mental health scores and things like that, you can have a mini mental score of, 18 out of 30 and still retain capacity. It's a question of whether do they understand what VAD is, what it means, what they're asking for, what the import is.
Yeah. There's another question here. I guess it's more about palliative care's willingness to engage on VAD. In your experiences, do palliative care services readily provide information about voluntary assisted dying?
Can I say something about that?
The honest answer is
Go,
Sarah.
Sandi.
Sorry. Not from us, no. In Victoria, no, we don't. But the nurse navigators that we have in Victoria will definitely be able to give out information. But once someone has actually asked us about it, we can definitely share information about the process then. But there's no leaflets or anything that we hand out.
Sarah?
I think it's very variable, but certainly the law in the Western Australia says that if a patient asks about VAD, then you're allowed to give them information, and we have printed booklets. And equally, there is an obligation that if during a medical consultation a patient makes a request for VAD, even if you personally object, you must in law register that request. It's not saying that you accept it or are going to take it any further, but the law for us says that you must register that request. And the law also says that you must, as a doctor at that stage, hand the patient a particular booklet. And we are actually now taking to task those people who have perhaps not realised that that is an actual obligation in law.
Yeah, it's Rohan here in Queensland. It's the same. I think Victoria's certainly different. I gather South Australia's got similar to Victoria, but New South Wales is more akin to Western Australia and Queensland. Around that, the obligation for the practitioners, I was saying before, is not fully known by a lot of the doctors, I think, and that's where some of the problem is, that they don't actually understand in law that they actually have an obligation. And in Queensland, it's very specific, around 20, it's straight away or within 48 hours, and you're not allowed to obstruct. You have to at least give them the QVAD support number to follow up.
That reminds me of a question that came in actually from participants before the webinar, and it was about consistency between palliative care units and are they consistent in their approach? And I think what we've heard is that they're not consistent. Things are different in different states, and even within one state you could have palliative care units or community services that are different. But that struck me that it's probably an opportunity for us to do a bit of wishful thinking about the future. I think it's pretty clear that voluntary assisted dying is still a relatively new service, and still the systems are maturing, and there's still a lot that we need to do to educate people and to understand how assisted dying fits in with palliative care. But if we were to look 5 years into the future and you had the magic wand and you could predict what it might look like, or you even had your way of creating what 5 years might look like, what do you think it'll look like for people trying to navigate assisted dying in 5 years' time? If we do a good job, what do you think we'll be able to see in terms of the linkages between palliative care and assisted dying? Would you like to have a go, Rohan?
Yeah, look, I would hope that it would be pretty well integrated, that we would be focusing on patient choice, that also it's consent in terms of fully informed consent, and that it really is important that patients get the full range of choices, from active treatment through palliative care through to VAD, and allow them to make that choice. I would hope that in 5 years' time we're looking instead at, well, what's happening with advanced health directives and all of those issues, and what happens with capacity. If you put it out in an advanced health directive, rather than this sort of thing of looking at, whether you have to negotiate your way through the navigator service and coming across all of this. I hope that it's become, Sarah put us a lot more mature down the track. Just to throw an aside in, I don't know whether you realise that back in the 1800s, that palliative care was actually regarded as euthanasia, because a lot of people felt that you interrupted spiritual growth through diminishing suffering. And so, things have changed. There's still some people that are a bit concerned about palliative care. I think this is probably going to remove the concern about palliative care to now talk about VAD. So hopefully in, less than 100 years' time, VAD will be just part of the general conversation. If you get anyone from Netherlands, they can't quite work out what's going on. Even I've had families and the children have said, well, we don't understand what the big issue is, because that's the way we've always been brought up.
What about you, Sandi, in the community? In 5 years' time, what would you like to see happening and in place?
I would like people to be actually talking about it, and it's not going to be hush-hush business. And I would like people to accept that palliative care is about living and living your best life, and not have turn up to patients' houses and them saying to go away because they don't want palliative care. I just want it to be easier, because at the moment I think that me as a nurse particularly, I feel like I'm getting tired of having to advocate for my patients and have to really, push other people so that they can have their rights. And I don't want to do that in 5 years' time. I'm too tired. Yep.
Sarah, what about you? Magic wand, what would you do in 5 years?
I actually don't think we need a magic wand. When I look at where the changes we have achieved in 2 years in WA, I'm not saying it's going to be perfect in 5 years, but healthcare is not perfect. And palliative care itself has fought for a position in healthcare for a long time. But I would be surprised if 5 years from now, we don't find ourselves just naturally in a position where people have more confidence, more understanding. And at the end of the day, this for me, Rohan talked about, it's about patience, and it's about care, and it's about kindness, and it's about putting other people before ourselves. And look, there will always be some roadblocks, but I maybe I'm an optimist, but I actually think that genuinely people and the number of true conscientious objectors is small. And I think a lot of the objections will soften, because people will see that this is practical and caring and possible and doesn't necessarily overwhelm people with work. But I think one of the reasons still that, that things stand in the way is it can be very hard for the doctors who choose to provide voluntary assisted dying to find the time to do it, to be adequately funded to do it. Because if you need to leave your practice to do long consultations with patients, to visit them at home, I'm not saying we should incentivize people to do VAD, but we shouldn't make it difficult and financially penalize the doctors. And in the longer term, it'll be nurse practitioners, other people as well. We shouldn't penalize people for providing a legal and kind service. So that would probably, for me, be the thing that we need to just sort out. a little bit more about the finances and the practicalities.
So Sarah's touched on another question from attendees here, and I think they are linked. So the question is, are VAD and palliative care free for everyone? And off the back of that, then, how are VAD practitioners remunerated? How are they compensated for their time and their services?
That's yes, good question.
Rohan here. Look, I guess if we look at New Zealand has actually got a central system where you can be a registered VAD practitioner and you can then assess the patients and take on and get centrally funded. Unfortunately, in Australia, we don't have that. So there is a range. You will get private practitioners that try to do it for, a fee that they're able to manage. You'll get others who will just do it for their own patients, knowing that it's going to be very time consuming. And the Medicare benefit schedule is not going to meet anything like the sort of, 7, 8, 10 hours, whatever it is, trying to get all the information together to do all your assessments and find another practitioner that's willing to do some of it, so you can have your 2 practitioners. And so it is an issue. It's going to be something that we're going to have to lobby for, to try and work out some sort of an MBS item numbers, the private health insurers, everything has got to come on board and start looking at it in a reasonable manner to remunerate people reasonably for it.
Yep.
Sandi, for nurses might be different. What's the story for the community providers?
We're just on wages, pretty poor wages, but so we just do it as part of our care. Yeah. We don't, it's not actually paid at a VAD visit, it's a palliative care visit.
Sarah?
I've been very fortunate that the service for whom I work has said to me that if I feel that I need to participate in a VAD process for a patient who's an existing palliative care patient, that's part of my palliative care work, and I'm a salaried doctor in that service, and that's how I'm able to do it. But for me personally, if I wanted to try and take on some more VAD work, I would need to give up another paid job. And so, I think Rohan's right that there has to be, like every medical service these days, or every healthcare service, there is a fee attached to it, and it has to reflect what is being provided. And if a service takes 2 hours to provide, you need to pay 2 hours, and if it takes 8 hours. So I would say that the doctors I know in Western Australia who've provided a lot of services are really doing it as an act of love, because I think every single one of them is out of pocket at the moment. Not to mention the fact that they're going out after work, they're going out on weekends, they're driving to quite, inconvenient places. And what we are struggling with is we just can't find enough doctors to actually provide the services required, because people just don't have the time.
I think maybe in the interest of not eating into people's evening too much further, we might sort of look to wrap up, but I thought I might ask the amazing panel one last question, if you'll indulge me. The topic of tonight's webinar was really about how can palliative care and voluntary assisted dying work together to deliver, choice for people at the end of life. I just wondered if you had a couple of thoughts, each of you, about, is there any key messages that you'd like to leave with the audience about how you think we can ensure that palliative care and voluntary assisted dying work seamlessly together?
Yeah, Rohan, I'm happy to. I guess it goes back to, look, if we focus on the patient at the centre, and we need to make sure they have enough information to have informed consent, and then they make the choices, and we support them in whatever choices they make, whether they've made a choice to go on for the next lot of chemotherapy trials, which we know are going to be futile, but that's what they've chosen to do, well, we still provide them with good symptom management. If they choose VAD, that's fine. We provide them with good symptom management because we're patient focused, and we'll do that all the way until the until the end, in whatever way the end occurs.
What about you, Sandi? What are your thoughts on how we next step?
The advice that I would give to patients or people that were seeking any end of life care choice, it's actually not my own. It's actually something I borrowed from a patient's wife, because I asked her once, what advice would she give to people, her husband, and I said, what advice would you give to other people if they were trying to figure out their end of life options? And she just said to me, don't be afraid. She said, keep asking questions because you'll find that people will help you. And so she just said not to be afraid of asking. So that's what my...
Fantastic. And Sarah, any last thoughts?
My thought is that we rarely win battles with big sticks. Beating our colleagues over the head and saying that they are bad people and they're not pulling their weight is never going to win. I think we need to have dialogue. And I think if we keep talking about real patients and real experiences and providing care, I think the vast majority of people will actually see where this can work together. You know, and I think if it comes from a point of view of care of our colleagues as well, I think we will achieve more than ever allowing ourselves to have a big dividing line and saying for or against, or we're the good people and you're the bad people. Yeah, I think being kind to one another will help us be kinder to patients.
Yeah, lovely note to finish on. Steve, is there any last extra steps for us with the webinar? I know we have a page that we're going to display at the end of the webinar that's got the details of the care navigators in each state. So if anybody on the call would like to wait and check out, they can actually write down the details and the contact numbers for those services. Steve, anything else we need to cover before we wrap up?
I think that is about it. I think all those details there for the care navigators now, if people want to jot them down. And I think that's about it. Over to you, Linda, for the last words.
So, of course, firstly, thank you to Rohan, Sandi and Sarah for giving up your evenings. I know you've all got busy clinical loads and this is at the end of a busy day. So we really appreciate your time and energy and passion and support of people through both palliative care and voluntary assisted dying. Also wanted to acknowledge that this webinar was really made possible through the fact that there's a Dying to Know Day and an organisation that promotes the Dying to Know Day. I'd like to thank them for the opportunity and for the work that they've done to really encourage conversations about death and dying and choice at the end of life. The day, 8th of August, is the official Dying to Know Day, so keep an eye out for events all around the state and all around the country. So thank you to everybody who joined. We had a fantastic level of engagement. Thank you for your questions, and we look forward to seeing you all on a webinar again in the future. Thanks all.